Do I need to speak into the mic?
No,
you'll be fine. Right. So my name is Anant. I am a healthcare person by background. So I'm sort of I have a quasi imposter syndrome in the midst of you environmentalists and ecologists. So I wanted to put that disclaimer up front. They have a slightly more probably health and healthcare oriented view of nature. So I was just going to talk about this CARE project, which we started with Natural England. But then I thought that maybe because I'm coming from healthcare, I would maybe give a little bit of an overview of how I actually got here to doing this sort of project. So if we look at health outcomes, and we can disaggregate that into life expectancy and quality of life, and there are debates whether those are the best metrics, but at least they're normalizable across both space and time. If we look at health outcomes, clinical care, so this is access to doctors, nurses, hospitals, pharmaceuticals, only accounts for about 20% of health outcomes. The other 80% are these determinants of health. Education, employment, housing, air and water quality, alcohol and drug use, diet and exercise, tobacco use, etc. And when we're looking at improving the health of the populations, at Jeffrey Rose, anybody heard of Jeffrey Rose? Okay, so Jeffrey Rose was an epidemiologist at the London School of Hygiene and Tropical Medicine. And he wrote a seminal paper in 1985 called Sick Individuals and Sick Populations. And what he was really focused on was how do we actually improve the health of the populations? And so if you sort of heuristically take this diagram of looking at population health and risk profile, you have risk of getting severely sick. So severely sick would be having a heart attack or stroke or dying. Low risk, medium risk, high risk on the axis, and you have the percentage of the population. And what Rose says is that if this is our baseline curve, normal distribution, most healthcare systems focus on the highest risk groups. So these are the folks with type 2 diabetes, high blood pressure, smokers, they drink too much, unhealthy diet, etc. And what Rose says is that though these guys are the highest risk group, if you look at the aggregate morbidity, mortality, and spend, it's always in the bell-shaped curve, despite them being lower relative risk. And what Rose says is if you want to improve the health of the population, you have to shift the entire risk profile to the left. If it does not shift to the left, it will continue drifting to the right. And as it drifts to the right, the intensity and cost of interventions will always continually increase. So I started working in the England Department of Health in 2011. England Department of Health mandate is delivering universal health care to people in England, so about 67 million people then. We were spending 110 billion pounds per year to deliver care. Fast forward to 2019, pre-pandemic, we were spending 140 billion pounds, 30 billion pounds more. Life expectancy declined for the first time since World War II. Health inequalities increased as well. Fast forward to now, we're spending 185 billion pounds of taxpayer money on the NHS, 75 billion pounds more. We have a 6 million person backlog. Health inequality has gone through the roof. Life expectancy has also declined. So we're spending more, we're getting less. And we're seeing this rightward drift in real time. Looking at Oxford City, so a population of about 160,000. So here, compared to Blackbird Leys, which is about 2 miles east, there's a 9-year difference in life expectancy. And if you look at Oxfordshire as a county, about 700,000 population, there's a 14-year difference in life expectancy between the healthiest and the unhealthiest parts of Oxfordshire. Now, we have a universal healthcare system, and in Oxford City, we have 3 world-renowned hospitals. We have the #1 ranked medical school in the world for like 15 years running. We have 80 GP practices. So despite all of that access to healthcare, people are still dying younger. So it's not because of access to healthcare that people are dying younger. It's all these other things, these other determinants. So if you guys have been over there, in Blackbird Leys, the county council did this little exercise where they looked at the cost of different types of food. So a banana in city center will cost you about 10 to 15p. You go over there, it'll cost you about 75p. So they have less money and the healthier food costs more. So this sort of begs the question, does everybody have an opportunity to be healthy? So this is really taking sense capability approach. Does everybody actually have an equal opportunity to be healthy? So you could take a libertarian perspective and say that, no, we don't want to be a nanny state and we don't want to impose sugar taxes, et cetera, et cetera. But I think a more fundamental question is, do people even have an opportunity to be healthy? I think what we know, I think we kind of know the answer to that question. So this was from the BMJ in 2018. And basically says something that we all know. The lowest socioeconomic groups are unhealthy. And they have this bad choices in quotations. The unhealthiest people, the people of lowest socioeconomic status, are making bad choices. And the question here is, what choices do they have? So Tower Hamlets, anybody been to Tower Hamlets in London? A borough in London? So Tower Hamlets has a childhood obesity problem, and they also happen to have 42 fried chicken shops per secondary school. 42 fried chicken shops per secondary school. So you could educate these kids to your heart's content. I was at a genomics conference. My background's I'm a molecular biologist. And I was at a genomics conference in Rome in 2018, and I was speaking about this stuff. And I said, you could take the full genome sequence of every child there, but as long as there's 42 fried chicken shops, you're not actually going to make any dent on this problem. This was during the pandemic, when we had the cost of living crisis and the heating versus eating debates. This was in the BBC. And then you look at the other side. So during the cost of living crisis, there were 62 new food billionaires that were minted. 62. These bonkers. The profits increased by 45%. This was done by Oxfam. But what's going on? People in Cardiff eating pet food, and then these guys are wondering which new Ferrari to buy. So we are drifting to the right, and from financial terms, that's about 127 billion pounds per year. On these long-term preventable conditions. And I say preventable because diet and exercise can actually prevent a lot of these conditions. Stephen, it almost seemed like Stephen had seen my slides before. He was talking about stuff that I was going to be speaking about. So I think there's great alignment there. 86 million antidepressants are prescribed to about 8.6 million people. And I say people, not patients, because they're overprescribed. So that's double from 2011. And it's not associated with any improvement in mental health outcomes. So we're spending a lot of money on these antidepressants, but it's not actually having any material difference on the mental health of the people that are actually getting these pills. And again, that's our money. That's our money. That's taxpayer money that's being paid to prescribe these pills. So macro and then go micro. So this was a project that we did, Research England funded. We worked with 3 primary schools in Oxfordshire, 126 kids in years 5 and 6. And we had them wear an activity tracker, which tracks basically an accelerometer for 7 days, 24 hours a day. And we wanted to see what proportion of their days they were actually physically active. So we have sedentary, which is sitting or lying down, light physical activity, which is standing or slow walking, moderate, which is walking, bicycling, or gardening, and vigorous, which is running, football, and over 10 miles per hour bicycling. 75% of that week, they were sedentary. 75%. 20% they were light physically active, and 5% moderately physically active, and none of the 126 kids were actually vigorously physically active. But what's going on? And then we also did the beep test. I don't know if you guys are familiar with the beep test, but they start from this cone, they run 20 meters and run back, and then you measure the time that it actually takes. So the blue is international comparators, and green is our kids. Look at that. We have some slow kids. What's going on? Like, these are the basics. You have, world-renowned academic medical center, blah, 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 but we can't get kids to run. Like, what's going on? We can create COVID-19 vaccine, but we can't get our kids to run. So why are we so slow, inefficient, and ineffective at left shifting? So as Rose says, left shifting. Because there's a lot of money in sickness. And I'll talk about two general business models that create sickness as a negative externality. So it's not like the McDonald's and the Krispy Kremes, et cetera, are saying, oh, we want to make everybody unhealthy. But they're incentivized to sell as much as they possibly can. And the more incentive they have to sell, the more they are going to try to sell. The more they sell, and the more that people actually eat that stuff, the unhealthier they're going to get. And if I just look at processed food, soft drinks, and fast food, that's about $525 billion in revenue every year. And then we also can't let our NHS and our healthcare systems off the hook either, because sick people, based on how our care models are actually set up, are the inputs for all of how care is actually delivered. We don't deliver health. We're just trying to prevent disease, trying to prevent exacerbations of disease, and keep people living as long as they can. And that's 127 billion pounds that we spend on NCDs, these preventable conditions. That money is going to GPs, to nurses, to physiotherapists, et cetera, et cetera. And I'm not saying that they shouldn't be doing that, but what I am saying is that that's our money. So why aren't we trying to get that repurposed to actually deliver health rather than just prolonging sickness? It's very skewed business models and care pathways that we have currently. And if we look at an EU level, that's 700 billion euros per year that we're spending on these completely preventable conditions. The opportunity cost, again, all taxpayer money because they're universal healthcare systems. The opportunity cost, just imagine the opportunity cost. We keep crying about money and not having enough funds for green infrastructure and green investment and education and stuff like this. Look at all the money that we're spending on these sorts of things. And if you look at the hidden costs of our global agri-food systems, that includes the direct and indirect costs. It's about 10 trillion per year. Per year. Bonkers. And when we're looking at the power within the systems, so this was published earlier this year. In the EU, about 1,200 times more public funding and 3 times more lobbying money goes to animal source food products. As compared to plant-based. We're quite skewed in terms of how we're actually designing our systems. And again, these are public subsidies, so that's our taxpayer money going to this stuff. And England is not that much better when it comes to this stuff. The National Food Strategy, Dimbleby's National Food Strategy was great, but it was basically tabled, which is the same thing that happened to the Farm to Fork initiative in the EU. So these are large multinationals and their shareholders. So I'm not saying private sector, I'm saying large multinationals. And this is nature and in Europe's future. And we keep getting our asses kicked over and over and over again, basically. And the cops were basically the same as well. You have these oil and gas czars leading cops. Like, you couldn't make this stuff up. So what can we do? So that's my journey here. And then horse rittle. Anybody heard of horse rittle? Wicked problems? Have anybody heard?
Wicked problem.
Wicked problems. Yeah. So this is the chap that came up with the phrase wicked problems. And a seminal paper in 1973 with a chap called Weber. They were based at University of California, Berkeley. And they're looking at these complex wicked problems, which I think what I just presented, I think we would all agree is a complex wicked problem with all sorts of incentives and disincentives that lead to really bad, messed up societies and behaviors. And what Ritchell says and Weber is that we can't find solutions to this. It's not like a natural experiment where you can have control over all of the elements and the inputs and the variables. Social problems are never solved. At best, they are only resolved over and over again. I'm presenting this because this is the mindset that I've been taking for the past decade. Whether rightly or wrongly, I don't know, but it's sort of my vantage point. This is where the sort of input into how care was designed. And he defines innovation as a social activity, which is quite interesting, isn't it? A social activity. So it's not just gadgets and gizmos and not ChatGPT and getting server farms, but a social activity towards controlled change of a particular object system with respect to a given pattern expectation and a predetermined purpose. So If you take that here as an example, it would be to convert the 10 trillion into delivering benefit and delivering health. So that would be our predetermined purpose. And what I'm not advocating for is that the multinationals go bankrupt, because they create jobs and all that sort of stuff. But they shouldn't be making money at the expense of all of the other stakeholders and entities in society. That shouldn't be allowed. And so, again, this is sort of the general approach that I take for many of the interventions that I engage in. Engage stakeholders, use a systems perspective, be adaptive and iterative, and focus on learning and improvement. And again, you don't have a solution. You're just creating a resolution over and over again. Because the other entities who are actually incentivized based on the current system are not just going to sit on their hands while their market cap is being eroded. They will adapt and adjust. So the public health folks really, really liked it. Ronaldo, anybody know Ronaldo? You know, the football player? Yeah, so, you know, he was at the, I'm an American football guy, but he was at a press conference and you know, Coca-Cola was sponsoring it, right? And then he was at the microphone, there was a Coca-Cola bottle there, and then he put it like that, and he said, agua, agua, you know, water, water instead of Coca-Cola. And Coca-Cola lost 4 billion in market cap. And the public health folks were like, oh, wow, that's great, that's great. But what our dear public health colleagues didn't look at, so if you look at a graph of their market cap, so it was here, it was down 4 billion. And then afterwards, you have to see what happened. It went above what it was before. Because the shareholder's not going to sit there because some stupid football player moved your Coca-Cola bottle. This is money for them, right? So the shareholders, Warren Buffett, one of the major shareholders, probably got on the call with the board and said, oh, you know, you better get your act together and get me my money back. And so Coca-Cola went into high gear and they made more money than they made before that. So again, it's not a solution, it's a resolution. And the other entities that are benefiting from the current system will continually adapt and adjust. So this is the sort of approach that I take generally. So looking at how we can work with these determinants of health to actually drive this left shift forward. And really looking at power. So this comes from Popeye. I don't know if you guys are familiar with Popeye, but there's massive power imbalances within the system. And you have these sort of 4 categories of power: power within, power to, power with, and power over. So power over would really be sort of regulatory elements. And we look at some of this stuff in the macro level work that we do. But a lot of what I'll talk about today will be power within, power to, and power with. We're looking at individuals and small communities. Because I think that's, again, more aligned with what Rittel and Weber were sort of talking about in terms of their innovation activities. But just before I go to that, if I look at a macro level policy, and again, Stephen was talking about this, so it's just uncanny. We have about 15.6 million people who are classified as being obese in England. And if we give this Wegovy drug, the semaglutide, anybody heard of Wegovy? People heard of it? So this is miracle obesity cure. And it's not that much of a miracle, really, because you have to, it can reduce your BMI by up to 10%. It does not reduce your BMI unless you combine it with physical activity and dietary interventions. And once you start taking it, you can't stop. If you stop, you gain your weight back. So at best, you go from obese to overweight. You don't go to normal weight, right? Because somebody who's obese and loses 10% of their BMI is still going to be overweight. So they're still going to be at risk. Once you start taking it, you can't stop. In England, we have, you know, we've been able to negotiate the price down with about 1,200 pounds per year per person. In the US, it's $1,000 per month, 12,000 per person. So that would be about 18.7 billion pounds per year of taxpayer money, our money, on that drug. Versus school meals. So this is, you know, the phenomenal work, I think, that was done on the school meals, which is about 440 pounds per child per year. That would be about 5.6 billion pounds. And here, you're reducing obesity rates. So you're preventing the kids from getting obese in the first place. In the evaluation they did, it also showed that it improved reading comprehension, and it relieved stress on the parents because they know that our kids are having a decent meal at school. And if you scale this up nationally, it could deliver so many other benefits. So this money, Wegovy, and Wegovy is, I mean, Novo Nordisk is interesting. So I'll give you sort of three ranty anecdotes about Novo Nordisk. Firstly, the entire country of Denmark was going to be in recession this year, if it were not for Novo Nordisk. So Novo Nordisk saved the entire country from being in recession. That's one. Two, Novo Nordisk now has a market cap higher than the entirety of Denmark's GDP combined, apart from Novo Nordisk. Number three, Novo Nordisk now, the Novo Nordisk Foundation now has more money than Gates because of the money they made from this drug. And that's problematic because firstly, that money that they're putting into the Novo Nordisk Foundation is money that they're not paying taxes on because it's a donation. So that's not going to society. And number two, now they're able to control the agenda of what is and is not researched. Because now the academics are just slobbering over, like they do with Gates, the Novo Nordisk Foundation, to try to get cash for their research projects.
They've got beautiful chairs in their offices as well. Really, really nice offices.
Danish furniture design.
Oh yeah, yeah. I mean,
Go all out.
they're not short cash.
Yeah, so it's quite weird, isn't it? These macro level business models, and how we're spending our money, because that's our money. So what I'll be talking about for the rest of the talk is the non-medical interventions and social prescribing. So this is stuff that I did with NHS England starting in 2020 up until now. Social prescribing, I think most people are probably familiar with. These are non-medical interventions designed to address social determinants of health. This is the Social Prescribing Observatory that we created at Oxford. So the RCGP RSC Research Surveillance Center is a data set of 2,000 GP practices, nationally representative across England. They upload their full electronic health record data sets twice per week. That data is pseudonymized and is made available for surveillance and public good purposes. So surveillance for influenza, swine flu, Ebola, COVID-19, etc. And then it's also made available for public good purposes, which is what we did here. So we covered social prescribing utilization, social need, and non-medical interventions. Now, one caveat around all of this is that we're only able to see what has a clinical code. So if you don't have a clinical code for an intervention in the electronic medical record, then we are not able to capture it here. So for example, there's 350,000 clinical codes, things like aspirin, type 2 diabetes, foot ulcers, high blood pressure, different levels of high blood pressure, different dosages of medications. So if I'm the GP, somebody comes in, I diagnose them with type 2 diabetes, I type in the code for type 2 diabetes, and then they have, mild to moderate type 2 diabetes. So I give them metformin, which is the entry line treatment. I give them a dosage, and I type all that in using codes. Those codes go up, and then that's recorded on the patient's record. And when I have the code for metformin, that is then going to the pharmacy. So that's how entities get paid within the NHS. So if you don't have a code, you can't get cash, really, within the care pathway, the normal care pathway. There are other ways of getting it, but it's not as seamless. The reason I mentioned that is because if you look at green prescribing, and Wendy and Kim and I were talking about this
last week.
I think there's only about 5 or 6 codes. And there's no dosing for the codes either. And by dosing, what I mean is, are you walking once a week, twice a week, 5 times a week, 30 minutes, 1 hour? Are you doing urban walks, gardening, et cetera, et cetera? There's only about 5 or 6 codes on that. And if you don't have those codes, then you're not going to get it integrated seamlessly into care pathways. So when we did this analysis looking at 2020 and 2021, we looked at social need. So these are instances where a social prescription could be helpful. So these are people presenting to primary care. There were 15 million instances of people presenting to primary care, the GP practices, with a social need that could have benefited from a social prescription. But there was only about 4.4 million actually given. So over threefold less. So these are missed opportunities to actually help people. And again, I take you back to the sort of antidepressant stat. a lot of times we'll just medicalize this stuff and we'll give them pharmaceuticals rather than actually getting them into the community with these non-medical interventions. This was another study that we published in 2022, where we looked at people with an initial diagnosis of high blood pressure, hyperlipidemia, or obesity. We wanted to see within a 2-year time frame. So this is where they get their diagnosis. So 1 year before, 1 year after, what proportion actually got a lifestyle intervention? And the reason we wanted to look above and before and after is because it's not like somebody just overnight becomes obese, right? You know, if they came into the GP surgery, they would have had their blood sugar measured. They would have seen, okay, this person's pre-diabetic, etc. So that 1 year time frame is the ideal time to actually intervene. And you can see the proportions. Only about 50% are actually getting any lifestyle interventions in a 2-year time frame. So again, missed opportunities. This is another analysis that we did. This will hopefully second round of revisions. We paint this one. But we're looking at physical activity interventions for people with a non-communicable disease. And the thing to note, these are the different regions of England, and we looked at a 4-year time period. And the thing to note is that we don't go above 45% in terms of people who could have benefited from a physical activity intervention actually getting one. And the Southeast, that's us, look at where we are, less than 20%. This is why kids can't run. This is mental health social prescriptions. Here, I mean, you have this blip in London. But apart from that, you can see that it's really low. It was climbing, which is good, but still less than 20%. So the role of nature and left shift. I mean, I think you guys are familiar with this, so I'm not going to spend too much time going over this information, but I mean, there is evidence that exposure to nature is beneficial for health and well-being. So I'm going to talk now about some of the projects that we started from 2020 until now, which led to the CARE project. So Green Space Hack was the first one. This was a Research England funded project that we did with OpenStreetMap, and it's something that Martha and Ella and I have been discussing as well for Green Space Go, to see if any of the stuff that we did for that project could just funnel into what you guys are doing. These are open source apps on the App Store and the Google Play Store, where people can kind of talk about and record the quality of the green spaces around them. So this, you can hover over, this is the Southern Road Recreation Area. So what we're not looking for necessarily is triple the size and NNRs, but any type of green space that people might appreciate. The other thing is we created this data explorer so people could we've made all of the data sets openly accessible so people could interrogate the data set if they want to look for example, in this geography, how many green spaces have parks. So it's really built on the kind of crowdsourcing ethos of OpenStreetMap. We held these well-being walks during the COVID-19 pandemic with Aspire and Blenheim Palace. So Blenheim Palace opened up their grounds, and Aspire is a charity that works in Oxford with people with substance misuse disorders or just coming out of prisons. They were struggling quite a bit. So we had maybe about 20 participants, and we did the ONS4 well-being measures. So this is their baseline, life satisfaction, feeling worthwhile, happiness, anxiety. And you can see the post-intervention of just the walks. There was at least some sort of marginal improvement. And one of the participants was going to fly to Inverness to walk from John O'Groats to Land's End. Because he'd been so socially isolated, this exposure to nature gave him this sort of new lease on life. Another participant kind of hooked up with one of the other people that was on the walks, and they started to start walking outside the group as well. And the really nice thing about this is that Blenheim and Aspire continue to deliver these walks 3 times a year to people from Aspire. So I think maybe 400 or 500 people have now gone through the program, which I think is really great. Green Space and Us, so this is Cowley Marsh. Lizzie Moore, if you guys know her. So Lizzie Moore and I and Louise, who's at NASP, worked on this. So we worked with these girls to identify what they wanted with the green space and what the problems were in terms of nature engagement. So the People in Nature survey for children found that girls engage less with nature, and girls of non-white ethnicities engage even less. And so we wanted to see what could be done to the green space to basically activate it, to make it more accessible and interesting for this demographic. And what they said was they wanted someplace that they could get away from their parents and they could hang out with their friends and they don't need to pay £3 for a tea or a coffee, where they could just chill out and with their friends and work on their homework and stuff. So they designed this. We had it built, and then, I mean, it took forever, like 8 months to get permission from the city council. But we got it in the end, and then we launched this last year in January. This is something that we've just recently done with My Vision. My Vision, again, is another Oxfordshire-based charity working with people that have visual impairments. And we did this pilot, it was Natural England funded, to get these folks with visual impairment to actually walk in green spaces together. And you can read the reports here, but you know, it started off just doing like a half a mile because they were so unfit and also kind of nervous. And by the end of the 6th walk, they were doing about 2.5 mile walks. The other thing is that they created this sort of collective vision, which I think is really interesting. So visual impairment doesn't mean that everybody's blind. Visual impairment means that some people will have low peripheral vision, some people may not be able to see colors or not see shapes really clearly, but together as a group, their collective vision was sufficient for them to be able to walk without a sighted guide. So this was done with Anita Lightstone, who used to be the chair of the RNIB, and she and I have worked together for over a decade. And she's also Oxfordshire based. And since that pilot, this is now expanded to 5 other locations, and we're looking to expand this. This also right. So now we come to the CARE project. So this was kind of the impetus of the CARE project. Sycamore Tree at Hadrian's Wall, top down. So all of the other projects that I've sort of talked about show the benefits of people being exposed to nature. But it comes at a potential cost as well. Now, this is like a sort of fat tail, long tail event. This doesn't happen all the time, but when it did happen, it's a big risk. So this sort of tied into Natural England's protected site strategies. People familiar with this? So we're basically looking at triple SIs and places of nature that are really important and valuable. And it's sort of directly linked to the Environmental Act of 2021, as well as the local nature recovery strategies. And the protected site strategies is sort of a means by which you can operationalize some of the stuff in the local nature recovery strategies, but also take a more kind of broad perspective, 5 to 10 years, 15 years in terms of what has to happen for that site. And CARE, Countryside Access, Recreation, Environmental Stewardship, is sort of underneath that umbrella. Natural England, I think, is funding 3 or 4 other projects under this protected site strategy umbrella. This is our awesome consortium. We have the Blenheim Palace, us, Natural England is the funder, but they're also integrally involved. So they're not a hands-off funder. They're actually attending all of our meetings, all of our discussions. So very, very hands-on, which is what we wanted. We have the Eden Project. We have the Ramblers, and the Ramblers we feel are important because they represent the community boards. And then we have the Oxfordshire County Council as well. The reason we wanted them there was because we didn't want to just look at honeypot sites. So Blenheim is really beautiful and it's great. Eden is beautiful and it's great, but it takes a lot of resource to go there. And if you're looking at nature connection and the benefits of nature, it's the little gardens like over there, or the university parks, the walks and the things that this group also does. Those are the sites that are probably going to be more important to people on a day-to-day basis. We need to understand from a resource perspective what is needed to protect those sites and to enhance them, and look at this balance between people being exposed to nature, but then also limiting the damage that they would have on nature. Now, this is an interesting and open question that we've had. So we've been working on this project for about 1.5 years now. And the design, we've been actually talking about this project for 2 years. It took about 6 to 8 months to scope it. And then once it was scoped, we started it. And this is a really fundamental question. It might seem controversial, but protecting sites So the default that most people will think of is protecting the sites from the visitors. But what we're increasingly finding is that they also have to be protected from the environmentalists because they try to become so protective that nobody can even walk on them. And you don't know what the answer to this is. This again is the horse ritual thing. This has to be the society coming together to find out what that middle ground is. We don't have an answer to this, but this is something that we're actively discussing. What should that balance be? Because Natural England is funded by the taxpayers, of course. And so should people have access to it? What level of access should they have to it? Should you take some of the stuff that Mondio was talking about, where you have these sites where nobody can ever touch, and then you have the other sites where people can walk around in? We don't know what that balance is, but it's something that societally we have to have a discussion about. So we have two kind of broad phases to the project. Phase one was looking at the barriers and facilitators and the types of irresponsible recreation that we were finding that were problematic for both visitors as well as site managers. We didn't just want to look at one stakeholder group because we wanted to see, again, from this perspective of looking at both of these entities as key stakeholders. What we don't have is nature's voice, but we expect that the environmentalists may represent nature's voice here. And then phase two is actually co-designing and evaluating solutions. So at both Blenheim and Eden, we're co-designing solutions, and then they have sister sites or buddy sites. So Blenheim is working with Chimney Meadows, and Eden is working with Galitha Falls. So preliminary results, this is still a work in progress. We had 289 site managers that responded to the survey. Once we publish this, it'll all be publicly available. The data sets as well will be publicly available for folks who use it. So blue is the most frequent, orange is the most damage, and gray is the most resource to fix. So at the top, you have dog fouling, small item litter, and dogs off leads as the most frequent. And then it sort of drops off to smaller vehicles, intentional damage, etc. Yes, visitors, the same questions, or sort of related questions, most frequent, most damaging. And then for the visitors, reduce their enjoyment of actually going to the space, and then decrease the likelihood of visits. So if we just look at the most frequent, we have the same. Dogs off leads, dog fouling, small item litter, which is actually pretty good to see that you have that coherence between the site managers and the visitors. What I think is really heartening is the decreased likelihood of visits for a large proportion of people, 30%, so that none of that stuff would actually decrease the likelihood of their visit. But what it also does say is that 70% would be turned off by some of these things. And then the other thing we wanted to look at, which is quite, sort of a nuanced way of looking at this, is when you're thinking about tackling some of these problems from a resource perspective, you have finite resources. That's money, it's cash, but it's also materials, it's also staff. Every time a sign is put up, it's like a 6-month process. You have to design the sign, you have to go through the various bits and pieces, the committees, etc. You have to make it, you have to have people install it, blah, blah, blah. So we wanted to look at this ratio between the damage caused and the frequency. So the question here is, are the most frequent instances of irresponsible behavior also the most damaging? And then we also wanted to ask, are the most frequent instances of irresponsible behavior also the ones that cost the most resource to actually fix? And higher than 1 is something that is not very frequent, but costs a lot to fix. So those are the things that folks should really, the site managers should focus on. And what you'll see here is that it's a different profile. So you have larger vehicles, large item litter, and theft as being having the highest ratios of damage to frequency. And if you look at dog fouling, dogs off leads, and small item litter, they're not well below, but they're not as bad as some of these other ones. For visitors, we looked at the enjoyment versus the frequency, and visit likelihood versus frequency. So again, same thing, above 1, and you don't see anything above 1 for those folks. And then we asked both groups about interventions. And again, it's quite heartening to see that better law enforcement and education were the two that came up. And education came up tops. So I think that's really, really great for both. I think the one that's most interesting for us, at least, is the changing of the physical environment. So the site managers didn't really think that that would have that much of an impact, not as many, whereas the visitors thought that it would. So creating different paths and things like this. So looking at the design of the green spaces. Phase two, so Blenheim is looking at soil compaction around the Harry Potter tree, which has become quite problematic. I think from some of the baseline measurements that we looked at, I think there's close to 50,000 visitors that go around the tree. And so that's having a massive impact on the Harry Potter tree. And Eden Projects is looking at small litter in the two biomes, which are right across from one. The final thing that we're looking to do is to create this responsible recreation network. So by site managers for site managers, and trying to get away from the kind of Google academic stuff. Because the site managers we spoke to don't read papers, academic papers. And a lot of times they do stuff based on hunches, and they take no baseline measurements. They take no post-intervention measurements. So they have no idea what stuff is working. But there's an opportunity cost because they're using resources to do this stuff. And sometimes you kind of on the fly, sometimes it's based on some sort of assessment that they've done. But if they have finite resources, then it would be best to use the resources where it has the most bang for the buck. So that's it. Feel free to get in touch with me if you want links to any of these folks. Wendy and Kim and Martha, I put them in touch with the folks that I know. So if you want links with any of these guys or any of these projects, just ping me.
Just to say that was awesome, and I'm like fully shocked and energized, and kind of just, yeah, I think it's just very valuable everything you're doing. This is kind of covered so much there, and I guess it's quite a broad question, but in terms of our role as researchers in public health, where do you think we could have the most? There's so much going on about the connections of green space, and you've made the economic cost, but I don't see that left shift happening, and I don't know if there's just a policy disconnect, or I mean, I'm sure there's some people that get it, but do we need to know more? And if it's this case, which area, or is this more about we need to get better at lobbying and talking? You know?
My personal perspective is we need to do public health in the wild now. We have to get away from these, and we have to get out into the wild, see people in 3D, and work with them. So what we're trying to do with the phase two is to actually empower the Blenheim guys and the Eden guys on how to do rigorous assessments. And it doesn't need to be labeled as research. It is academically rigorous and it's generating evidence. And what is research? It's basically finding as close to the truth as you can possibly get to a question that you're asking. So you're asking the question, and then in a structured way, you're trying to answer it. That's what research is. Anybody can do that. Nobody needs a PhD to do that. And I think what we need to do increasingly as a public health community is to get out into the wild and away from these things. Because unless we see these guys eye to eye, I don't think we're going to make shifts. Because these guys are so motivated to do this stuff. And there's also, you know, by public health in the wild, what I also mean is that there's a level of insecurity that these folks have when they speak to academics. Because, you know, they don't want to look stupid, they don't want to look dumb. So you go through a bunch of slides and a bunch of graphs, they don't ask any questions. It's not because they're not interested, it's because they may not understand what the hell you're talking about. And having a less charged discussion with them over a cup of tea or coffee, where they can ask those dumb questions, I think is essential so you can build that trust. So it's not a kind of just a one-off thing or a 2-month project or a 3-month project. These guys, I've been working with the county for 6 years. I've been working with Natural England for 5 years. I've been working with Blenheim for about 6 or 7 years. Anita, I've been working for 12 years. These are relationships that we have to have to develop with our communities. So it's public health in the wild, that's my opinion. And I think that can then translate, so I think Eric, I think, was talking about multi-level governance. I think this is multi-level governance in action, because then you can get the insights from the micro level and the meso level, and you can take it to the macro level. That's my opinion.
I don't know how to frame this as a question, so can I just do it as a comment and ask you what you think? But the thing that really struck, I loved all of it. It was brilliant. The thing that really struck me was the gap between the first section and the second section, and the macro stuff, the systems level stuff. And yeah, we should fix this, absolutely. It's bonkers. And then we should have a redistributive tax system to fix Piketty's capital thing. And we need systematic change to tackle climate change and biodiversity. And we can't do it. And I think we can't do it because it would require the kind of benign dictator that we can't find. And in a democracy, all the politicians are self-selecting, and we wouldn't trust any of them with anything like a sharpened pencil, never mind anything else. So we end up making an app and waiting 8 months to build a girl-friendly bench in a park. And it's the little stuff, and it's slow, and it's painful, and it's dirty. I think my real concern is that from the conservation optimism point of view, do we not drive ourselves, if we don't recognize our inability to tackle, we still think we can do some of the big stuff, and we set ourselves targets that we can't possibly reach, and then drive ourselves crazy. And how do we, some of this stuff so needs to be fixed, and our capability is little bits. How do we bridge that gap?
Again, the Eric comment on multi-level governance, I don't know what his perspective is on multi-level governance, but mine is the same as the community. We need to treat the MPs and the MEPs and the politicians and the policymakers in the same way. You're in the Department of Health, working with some of these policymakers. What do the lobbyists do? They're so successful. The 3 times the amount of money that's being spent on the animal product, these lobbies, they become friends with these guys. It's the hustle. They call them, they text them. Hey, you want to go to a rugby match? There's from a transparency perspective, the meetings that have to be disclosed, but then there's all the sort of casual things that happen as well. And we're very poor at that. So public health in the wild is not just getting in touch with the community, but also the policymakers. Because you go to a policymaker and send them an attachment of a 50-page article. They're not going to read that. They're not even going to open the freaking attachment. And if they opened it, the likelihood of them understanding it is very, very low. Which is why you have hundreds of scientists publishing 2,000 pages in the IPCC reports. Then you have an oil and gas company publishing something in a 0.5 impact factor journal. And then they're sitting with the MEP or the MP over a cup of tea or coffee or dinner. Like, line 3, paragraph 7 on page 1075. That doesn't make any sense to me. Don't you agree? While eating their steak. Like, oh, yeah, you're right. Whereas we are just very, almost overly too objective. So I think that public health in the wild is also getting in touch with the politicians so that when they are faced with something that's confusing, they pick up the phone or they text you and they say, hey, John, what do you think of this? And I think that's the sort of relationship that we need to have, because there's tons of science already, but it's not being implemented, as you say. But I think that's the impasse that we really, really need to break. I don't know how it can be done, but I mean, we do that in the Department of Health, for example, and we're just hanging around, and it's a different type of skill because it's not sitting in front of a screen. It's a hustle. It's a different skill set. You have to be friendly. You have to be nice. You have to be tolerant to stupid questions, and they have to feel like they're not being judged when they ask the stupid questions. Oh, sorry, I think she was first.
Okay. Very fantastic talk. Thanks for sharing. There's such a clear connection between going outside, access to nature and health, and it seems like we're making strides, especially with medical professionals prescribing this. My question comes from, I guess, my upbringing, having social, economic, and cultural barriers to access to nature. How do we make access to nature equitable, especially if it's being prescribed to people?
I don't know. No answer to that. I mean, that's a societal question that we have to kind of talk about. Urban design, urban planning, there's this really big, one of the things I comment on / probably rant about is this big push for like housing and stuff and biodiversity net gain. A lot of it is so BS-y, right? Because they'll plant a bunch of trees, but then nobody maintains the trees afterwards, so they just die. And at time t equals 0, they'll look at the biodiversity kind of net gain, but then they don't look 2, 3, 4, 5, 10 years down the line as to whether it's still there. With the big housing push, you're going to have to, I mean, you're looking at land use, right? I don't know how those decisions are being made or should be made, but it's a discussion that we need to have. I think, if you look at some of the Austrian examples, it certainly is possible to integrate little patches of nature. I don't think you're gonna get the honeypot sites, like Blenheim and Eden, but I don't think we necessarily need such expansive sites. I think like this is why we're working with the county council as well, is to see how some of these small spaces and just a little patch of land with a bench somewhere and maybe a field where people can play, maybe a little bit of playground equipment, a bench where people can sit and sort of chat. And maybe that's sufficient for people to have that access to quality nature and equitable access to nature. I don't have an answer to this, but it's a design question for sure. Stephen and I were talking about, Jane Jacobs stuff, about where green spaces should actually be located. And Jane Jacobs, people heard of Jane Jacobs? The sort of godmother of urban planning. She wrote a seminal book called The Death and Life of Great American Cities. She was working in Soho, and back then they wanted to build a freeway, like an 8-lane freeway or something monstrous like that through Soho. And she fought with the community to get that stopped. And she did this analysis, looking at the design of cities, and the ideal location of a green space is so that it's multi-use. And so her, sort of notion was you should have a green space in sort of the middle that serves as a throughway for multiple purposes. So you have the housing here, you have the schools there. So the parents go in the morning to drop off the kids, and then they bring them back in the afternoon. You can have some workplaces here, you can have some benches there, so that the people can walk to work through the park as well. So they're getting access to nature. And then importantly, they're always having eyes on the streets, so you can avoid the incivilities which lead to drug use and that sort of stuff in the green spaces. In all of the housing, Keir Starmer it was just published this morning that he's saying that the county councils have to build more houses. And the question is how? So I think all of this can be integrated into that, but I'm not part of those discussions. But I think that's something that we as researchers should advocate for. Get out into the wild and talk to the county. If you want connections, many of you know Lizzie, get in touch with her. Rosie is left. Stuart Cole is somebody that I've worked with for about 6 or 7 years. I can put you in touch with him. But if you have ideas, translate the knowledge into practice, at least here. And then it might serve as an inspiration elsewhere as well in the country.
If you're interested in equity of access to green space, that's something that I do a bit of with people. Well,
and this is Green Space Go as well, I guess.
Yeah.
Yeah, I do have a question. I think I probably asked you a bit last week. It is like you mentioned we don't have enough codes like in the system to kind of code it, the non-clinical treatments or the social prescribing. And then, so first part of my question would be like, how is that? So we have a like public health, NHS, we have a caring system. The caring system probably doesn't work in the way as it's supposed to be or as it's expected. So what is the kind of takeaway for the researchers in this area? Is like what sort of things we can change to that? And I think my second question is probably a bit linked to what they mentioned before. So we got local case studies like Eden Project, your amazing different kind of case studies. does that fit back into a bigger policies, or it's like talking to something in the Natural England about public health? Is that RNRS, or is there a GI framework? Or is it BNG, or is there some directions in the policy? I think for me, I also kind of worked a little bit with Natural England before, and I think Natural England, obviously, they're sort of little bit biased, I think, because they're coming from where they're coming from. So I was thinking, I was like, what is the angle that we fit back into, that we can talk to the right person that actually can make, hopefully they're gonna be a practical difference that we can make. So yeah.
I think maybe 4 points. Questions. The first is, even with the Natural England, it's a massive beast, so it depends on who you talk to. So the folks that I think I put you in touch with, I worked with for 6 or 7 years, and they completely get this.
Okay.
So I think it really depends. And then once you have that inroad, then you can kind of go up, and then they can maneuver around within the machine. So I think that's always important, even within the county.
Yes.
You know, Lizzie's easy to work with, Stuart's easy to work with. Not to say that the others aren't easy to work with, but this may not be their priority, it's not their mandate. And therefore, they're not going to pay as much attention to it. So you have to find the right people. Again, that's a hustle as well. You get into the organization, you have to kiss a lot of frogs to find the right person. So it's not, there's no empirical method to this.
Okay.
You have to try. So again, that's why I'm saying, if you guys want to work on any of this stuff, you want contacts, these are the people that I've worked with, get in touch with me. On the codes, it takes about 6 to 7 months to go through the process to create a new code. So the codes aren't static. Every time you get a new pharmaceutical, they're going to create a new code for it. So it's a 6 to 7 month process to create new code. And the third point is, the more fundamental question is, what should you create the code for? And this is where I think research can help. So, this is, in social prescribing, you know, somebody's diagnosed with type 2 diabetes at the age of 35. And we're happy to give them metformin for 45 years. But there's this real, in my opinion, moronic double standard, where for social prescriptions and non-medical interventions, we expect a 3-week, 4-week, 6-week course of that intervention to deliver and yield longitudinal benefits. Completely unrealistic. And I think what we need to do is design better interventions. And so I'm an immunologist by training. And so my ideal would be to actually create an initial intervention with boosters. So like we had for COVID-19, you get the initial dose and then you get a booster to boost your immune system. People need to learn, and people's lives are not static either. They lose a job, they lose a spouse, they have an argument with a partner, whatever it might be, they move somewhere else. So you get the initial intervention, and then you check in with them, say 6 months. I've just made this up, but 6 months down the line, you check in with them. How are things going? This follow-up intervention doesn't need to be as long, 2 to 3 weeks. This could be, say, 6 weeks. This is 2 to 3 weeks. But you do a consultative process. What's working for you? What's not working? Okay, let's try this. Let's try that. Let's try this. And then you follow up, give them another booster, see how things are going, and then another booster. And then you can take sort of maybe a 6-month gap or lag between the next booster. So I think the design of the interventions and how you actually frame them needs to be decided first. And this is where I think research can help. What is the type of intervention or the course for these non-medical interventions that actually yield the greatest benefits? The second thing is cost. So this, I pull my hair out, what little I have left, about the wonderful VCSE organizations not having any freaking clue about how much it actually costs them to deliver these interventions. It's so impractical. It's wonderful, it's beautiful, but it's not sustainable. Because you have staff time, even if you have volunteer time, you have material costs, etc. You need to know how much it costs to actually deliver the intervention. So for a person or for a group, you have a unit cost for the intervention, and then you charge for it. Well, no, sorry. You have the cost, then you put a margin on it. And then you charge that price. So there's your cost, and then there's a price. You have to do that. And it's not about making cash. It's about making sure that you have enough money for a rainy day and that you can scale both horizontally and vertically. What I mean by that is scale, most people think that you just reach a greater number of people. But for these types of interventions, sometimes what's needed is more vertical scaling. You have to go deeper with the individual to figure out what's actually going on for them. And that requires time. So both horizontal and vertical scaling, and there's a judgment call on that, but there's a cost to all of this. And there has to be some sort of sustainability for this, even if it's voluntary based, you know. So those are the things that I think research can help with. Yeah.
Fascinating talk. I like how you've, given us your story. It's a very nice story and it's very compelling. As a, kind of human behavioral researcher, I find so many things that I'd love to comment on and, kind of really pick your brain on. But one thing I wanted to just touch base on is the phase 1 of the care stuff. I find it really interesting about how the 2 most commonly prescribed potential interventions were education and better law enforcement. So I work in a marine conservation context. I work a lot on illegal fishing. And those are the 2 prescriptions that are most commonly used and that a lot of practitioners are now realizing aren't enough. So in some ways, what it may suggest to me is that essentially, we kind of go through this curve societally, or the managers or people, about, what are the best kind of interventions that we can design. And then we go and we push a lot for that. And in marine context, maybe they have specific challenges, like law enforcement is incredibly expensive to do it. I work on the Great Barrier Reef quite frequently. It's 3,000 miles long. They just can't be out there all the time. From a behavioral science perspective as well, we have this kind of issue around education does not necessarily lead to behavior change, right? So I guess I kind of make a lot of my work based on that education and how we message in the education to try to change behavior. When you move into phase 2, what exactly are you guys thinking about as far as, because I know phase 1 was identifying barriers and then phase 2 is kind of putting it into action.
Yeah, so the first thing that we're actually finding is great. I would written anything on the marine conservation stuff can used to be necessary but not sufficient. It would be great to get a better understanding of what else was necessary. But the other thing is, and that's what this is for, is particularly this for the site managers, is looking at the resource, the allocative efficiency, technical efficiency of how they're allocating their finite resources.
Right.
Where are you going to get the most bang for your buck? And what this does not talk about, it talks about the areas of focus, but what it does not talk about is the interventions.
Right.
What we haven't been able to get to is the costs of these interventions.
Yeah.
But I can take that this would be expensive. It may not be the best use of the resource. I mean, intuitively, the first thing that comes to mind is the Jane Jacobs stuff, where, you always want eyes on the street or the eyes on the sidewalk, because that's what leads to a reduction in incivilities. Because then people feel like it's theirs as part of their community and they have that ownership. I don't know how that would work in practice, but I think it would be education, but then also, what we're talking about here, and we wanted to include this word specifically, stewardship. So, taking the biblical kind of definition of stewardship, the good steward leaves the land in better condition than when they received it. And for Blenheim, what we're asking in terms of an intervention is almost an educational, provocative question to the visitors, which is, do you want your grandchildren to see this tree?
Yeah. So in the behavioral sciences, we call that a legacy prime. So
Legacy prime.
yeah, essentially trying to get people to think more about the future. I don't want to ramble here, but I find this so interesting. So I hope we can meet another time to discuss legacy prime. Think about the future. What that does is short circuits kind of that short-term planning horizon, which also works really well when you're dealing with people coming from socioeconomic neighborhoods, backgrounds that incentivize that short-term behavior again. So vividness and interventions are another thing that kind of deals with. They use it in health, they use it in finance, for savings, all sorts of different things. is kind of make that future vivid to the point where it then shifts decisions that are happening in the moment to where we're kind of pushing people into a long-term planning horizon, as we call it, which is super cool. Really interested in what you're doing. Would love to talk
Yeah,
more about it.
Again, we're open for collaboration, so just me. I mean, one of the other things that we're looking at potentially is taking a commons approach. So Ostrom, governing the commons. So how do you overcome a tragedy of the commons?
Mhm.
And if the community members felt like the Great Barrier Reef, in your example, was a commons for them. And the example that Ostrom gives in governing the commons, she gives several, but one of the ones that always sticks in my mind is the Torbell Forest in Switzerland, which for about 500 years has been managed as a commons. So the current generation will plant a tree that will not be harvestable for 200 or 250 years. So they're not even doing it for their kids or their grandchildren. It's their great-grandchildren that they're doing it for. But they're always thinking from that perspective, and they have that ownership of the commons. And Ostrom's 8 principles of how to govern a commons is something that we're thinking about. Is that something that we could integrate into this? Within the community, when the county council, for example, has to build all these houses, can we get the green spaces integrated such the community is actually taking care of it? Don't know, but would be, super interesting to explore.
Absolutely, absolutely.
I think we could pick your brains all day. Thank you. Incredible talk. I was terrified at the start of it, but thank you very much for leaving me with such a lot of hope and inspiration. So many synergies with people in this room doing similar things that, maybe please take those discussions forward. We have this room till 2 o'clock. Please, you're not allowed to leave until all the mince pies have gone. Okay, please. So please, if you have time to stay, I'm sure people would love to grab you, but thank you so much. Thank you.
Thank you. Share the slides as well, so I put all the references, and once we get the data sets, I'll share them.
Amazing. Well, if you're happy for me to send them around, I'll do so. Thank you.
Congratulations on your new job.
Thank you.
I'm staying in the UK.
Yeah.
Very interesting. Yeah, thanks for the quotes.
Absolutely. I was really